Hello, everyone, and welcome to the final webinar in a series of webinars on high-impact practices in family planning. This webinar series is hosted by the Implementing Best Practices Initiative in partnership with FP 2020 and the High Impact Practices Collaboration. My name is Nandita Tate, and I will be your facilitator for today's webinar. I recently joined the World Health Organization to lead the Implementing Best Practices Initiative, or IBP. IBP, with its secretariat housed at WHO, is a unique network of over 45 member organizations representing global, regional, and local NGO and civil society, with a mission to support the dissemination, implementation, and scale-up of evidence-based guidelines and high-impact programmatic practices. By partnering with FP 2020 and the High Impact Practices Group, we hope that these webinars provide a neutral platform to showcase evidence around various high-impact programmatic interventions and offer practical, on-the-ground implementation experiences. I would like to extend a sincere thank you to Ados May from the IBP Secretariat for leading this effort behind the scenes, and to all the IBP member organizations and other partners who have generously contributed their time and expertise throughout these webinars. We are happy to report over 200 registrants from over 35 different countries participating today. So again, welcome to you all. Our agenda today is full and should be very exciting. I will start by providing an overview of the High Impact Practice, or HIP brief. And then we will hear from an esteemed panel of experts who you see there that will present both the research and programmatic findings from various countries on this important intervention. Next slide. Again, the objectives of today's webinar are to ensure that participants have a better understanding about the use of vouchers, as well as to share some implementation and research experiences on implementing this important intervention. A few notes on logistics. During the presentations, please submit any questions using the question feature at the bottom of your screen. We will have some time for a question and answer at the end of the webinar. In addition, please note that the webinar will be recorded and posted on both the HIP and IBP YouTube channels. We will share the links to these recordings as well as the presentations with all of you, our participants. Finally, there are some handouts, including the HIP brief and some recent publications, that you can download to the right of your screen under the tab Handouts. Okay, next. Great. So quickly, a short background on the High Impact Practice, or HIP brief for vouchers. Next slide. The High Impact Practices, or HIPs, are programmatic interventions that have been organized into 3 different categories: enabling environment, service delivery, and social and behavior change. Next slide. The vouchers fall under the service delivery category, as they provide a change in the way services are organized or provided to improve access and availability of quality family planning services. Next. The service delivery and social behavior change HIPs are further categorized according to the strength of their evidence into proven or promising practices. Vouchers are unique because we are still examining the evidence around this practice. And in fact, today's presentations are especially timely because they will offer some additional evidence on what we know about the impact of vouchers on contraceptive use. Next. The HIP brief on vouchers, which again you can download under the Handouts tab, is organized in a simple way to help facilitate use for various purposes. The background section and the why this practice is important section offer insights into how and why this practice might be worth considering to strengthen an FP program. Next, concrete data from various field settings is presented to showcase the impact of the intervention on contraceptive use. The brief also offers some practical implementation experiences and priority research questions that we should consider to help further strengthen the evidence base around this practice. And finally, a detailed reference list is provided and is an excellent resource for those wanting additional information. Next slide. I would now like to welcome and introduce today's panelists. We have a range of panelists offering expertise in both program and research settings. We will hear from Elaine Minotti from USAID, Ben Bellows from the Population Council, Anna McKay from Mary Stopes International, and Mozam Ali from WHO. Next. Great. I would now like to welcome our first panelist, Elaine Minotti. Elaine is a technical advisor at USAID, where she works on the private sector team. Elaine manages health service delivery programs and supports public-private partnerships and strategic initiatives to implement total market approaches. Over to you, Elaine. Thank you.
Hello, everyone. I'm pleased to be part of this webinar on vouchers for family planning. My presentation will provide an overview of vouchers, how they work, and why we might want to use them in family planning programming, and serve as an entree to my fellow presenters who will share country implementation examples and research. Next slide, please. So vouchers are a financing mechanism, specifically a demand-side financing mechanism, meaning the focus of the program and its resources are largely directed at the client. But it's also a programmatic tool, a practice we can implement in family planning programs to help address specific challenges and barriers to access and use. Specifically, they're paper or electronic tickets distributed or sold at a nominal amount to select client segments to exchange them for products or services at accredited sites. Next slide, please. A question we hear a lot is, can't you just make services free? Making services free of charge for all is often noted as a way to improve equity. But in practice, we know that's not enough. That puts a supply-side intervention to a complex problem of access, and it may not be sufficient to reach those who face barriers to using facility-based services. The poorest often have lower rates of service utilization than their wealthier counterparts, and then they benefit disproportionately from facility-based investments often made. Health systems are, as we know in many of the countries where we work, are very stretched and face difficulties adequately financing and supporting health facilities and programs, particularly at the lower levels. So our solutions need to address a range of barriers affecting service utilization to reduce inequities. So in essence, vouchers really aim to address equity. They enable us to target subsidies to those who need them most, but also target those resources to the key services we want to support, and potentially, if implemented well, reduce other barriers to seeking care. Next slide, please. So what makes a voucher program? We'll hear about different programs today, and the details will vary, but each program really contains these components. We have foundational elements, which would of course include the source of funding, which could be donor or loan funds, but also governments, the objectives and time frame, and a governance structure. Management at the center would likely include a voucher management agency, which is in charge of systems and processes for administering the program, with providers, local organizations, and clients. The voucher management may include an external verification body if needed. Then we have providers of the facilities, and we need to determine type, location, and sector, public, private, or a mix of facilities, how to recruit, accredit, and panel and retain qualified providers to participate in the program, determining the service package and pricing, and then how voucher revenue could be used. There are clients, of course. We have to identify them, figure out how to distribute vouchers, how to promote the services to generate demand, and how to deliver services to them. Next slide, please. So in practice, how do vouchers work? They really function as a series of transactions. This diagram looks a little bit complicated, but it really maps out the key steps that take us from the voucher managers to the clients and through the system. Next slide, please. As with any complex intervention, the devil is in the details of implementation. Earlier, I mentioned that it's both a financing mechanism and a programmatic tool. If we want to improve behavior, improve uptake, we have to consider both supply and demand side issues. We want to include supply and demand related inputs. So in working with providers and facilities, we want to ensure family planning quality. So we would want to provide training, monitoring, supportive supervision, site improvements. There's also a demand side component that often gets underplayed. However, it's a very important component of voucher programs. It includes social and behavior change communication to reach the desired population. We really want to positively promote family planning services, create a buzz around them. And in our efforts to distribute vouchers, we have an opportunity to engage in client counseling, interpersonal communication. Our voucher program is really only as effective as we are in reaching the key segment we hope to reach. So means testing to ensure vouchers go to those who need them through geographic targeting and assets or other type of questionnaire, using already existing poverty grading tools or identification means like ID cards, or just observation in the community. There's really no one best way that we know of, and how to do it depends on the context. Ideally, voucher program revenue, or the reimbursements for services provided, goes back to the facility itself to improve quality, to add staff or providers, put towards facility-based needs, particularly since vouchers may increase the client volume in a facility, and it supports the providers. Next slide, please. So what can they do for family planning? Most programs are able to demonstrate an increased voluntary uptake of modern contraceptive methods. Ideally, we can also improve quality and even continuity of family planning services, but that has to be deliberate in the design. We can enhance method choice by offering a broad range of modern contraceptives and use vouchers to help us fill gaps. We increase the number and types of providers, creating a quality-assured provider network. In many countries, long-acting reversible contraceptives, or LARC, permanent methods, are much less accessible than short-acting methods due to health system weaknesses and demand issues. Vouchers may help us fill these gaps in provider-dependent methods as a proactive effort to make these methods more available and accessible. Reimbursement rates can level the playing field. Some methods, like IUDs or implants, are more costly than other methods to provide. Clients and providers alike may not be able to afford them outright in the absence of some additional subsidy or support. Particularly if there are a range and good number of facilities included, we can enable client purchasing power and provider choice by allowing voucher holders to vote with their feet, choose to go where they want, potentially yielding greater client satisfaction. And finally, we can potentially create a pathway for strategic purchasing like insurance or contracting out by accustoming providers to processes and systems like accreditation, reimbursement, oversight. We can understand what it takes to include family planning, as family planning methods vary in provision costs, and we often see that contraceptives are not included in insurance programs, or maybe just some methods, or in some way incomplete. And also including private providers in healthcare financing. Private provision in national health insurance programs is already a reality in many countries and will be needed in many to help countries with coverage and access. Next slide, please. So finally, I'll leave you with challenges and questions we ask, and some of our presenters will help us explore these. But is it too heavy an administrative lift, particularly at the outset, to set these up? Not every partner out there can take this on. Do we integrate or include family planning services alone? What are the unintended consequences on other service provision? We do know that it often increases service volume. Does it overwhelm providers and systems? How can we prevent that? How long do we sustain them? Voucher programming, the voucher program itself, though we feel certain aspects can be sustainable, like a provider network and creating a platform for other financing. And what else can we ask or monitor in these programs? In particular, can they help us improve family planning discontinuation, the source of a lot of program effort lost? What are the most important design features for success? So with that, I'll hand it back to Nandita. Thank you.
Great. Thank you, Elaine. That was a great global overview of what vouchers are and the potential they have to strengthen family planning programs. We also heard about some of the challenges and questions that we still must ask ourselves around implementing this important intervention. Thank you again. Our next presenter is Ben Bellows. Ben is an associate with the Population Council based in Lusaka, Zambia. He currently leads a 5-year initiative to measure the impact of reproductive health vouchers on health service uptake, equity, quality of care, and sustainability. On to you, Ben.
Great, and thank you very much for the introduction here. Today I'm going to speak about a study that was just published last month on an analysis using routine data out of Uganda, looking at a voucher and social franchising program that was run from 2011 to 2014. Next slide, please. The study utilized routine data, routine service data, and the Impact 2 modeling tool to estimate the impact of services and the program's contribution to national contraceptive prevalence, and to estimate the numbers of additional users at the population level, the number of additional contraceptive users added to this aggregate number of estimated users in the population. So we began in 2011 using the demographic and health surveys data, looking at a baseline of 34% of married women in that national survey, 34% of married women of reproductive age, indicating an unmet need for family planning services, so high demand, and noted inaccessibility to family planning, to contraceptives due to costs. There were lack of trained providers, particularly for LARC and permanent methods, and to some extent lack of consumer awareness and weak supply chains. A number of factors that combined are emblematic of the constellation of barriers that consumers face in many of the places in which we work. Next slide, please. An important element of that was that an additional challenge was recognizing, or an opportunity rather, was recognizing that 50% of Ugandan consumers were accessing family planning services through the private sector. And the private sector was not both an opportunity and a challenge, in the sense that many private providers lack the training, again, for LARC and permanent methods. And where LARC were being distributed in the private sector, the price point would make these products essentially priced out of range for many of the consumers who would have a demand for the product if it were more affordable. Next slide, please. So a program was developed that leveraged the experience of Mari Stopes in its social franchise network, the Blue Star Network, and combined that social franchise model with its emphasis on quality with a voucher approach, which is taking that proactive step forward into the community to raise demand, to generate interest in the potential for counseling and learning about contraceptives in more detail, and taking vouchers out into the community through community-based distributors to raise demand. So there were approximately 400 private facilities when the program was fully ramped up that were contracted to accept vouchers within this Blue Star network. And the aim was to increase access then to long-acting reversible contraceptives as well as permanent methods in this three and a half year period from March 2011 to December 2014. The family planning voucher covered the counseling for any particular method, as well as the high out-of-pocket costs for LARCs, permanent methods, and follow-up services such as LARC removal as needed. The voucher was intended for poor women who were identified using a poverty grading tool which was calculated or which community-based distributors used to assess the the status, the poverty status of potential beneficiaries at the household level through a series of short questions about the presence or absence of certain assets and certain products that were routinely consumed in these markets. Next slide, please. The study was looking at the program was looking at a voucher model, much like Elaine was already describing, with a voucher management agency and franchisor in this context combined, in which the marketing of the voucher, its distribution, was being managed by that voucher management agency, and the quality component through its franchising role was being managed as well. So there was a quality assessment, there was feedback on quality, on routine monitoring of quality, and so there was a mechanism to ensure that quality services were being provided at the standard required for the Blue Star network. There was this contracting mechanism where previously arranged reimbursement rates were established, and facilities were paid essentially on a fixed fee for service model. Claims were submitted for each client individually. These claims were processed. They were checked against irregular patterns and other irregularities that might signal potential fraud or potential concerns around the way in which the reimbursements would be paid out. So there was a check essentially to ensure that the claim submitted was a faithful representation of the service being provided to the client. And then there was performance monitoring and evaluation. There was feedback on the performance of the program over time. Clients were those that were deemed to meet were those that met the poverty grading eligibility criteria rather. They used the vouchers at the accredited facilities, and the franchised facilities, the providers, were those that were part of that Blue Star network. Next slide, please. The study in this case was using routine data, so this is not a large household survey that we're conducting. There was not a health facility assessment. This was simply using the available service statistics to estimate the program's impact using Impact 2. So we looked at number of pregnancies averted, adverse health and financial outcomes averted, and its impact on population level outcomes, and simply inputting the facility service statistics and some client demographics. Next slide, please. So from those service statistics, to give you a sense of the scale, how many services were provided at these 400 facilities, there were 330,000 services provided to voucher beneficiaries at these facilities. Now there were other non-voucher clients that were also visiting the franchise facility. So there are additional benefits to the population beyond those that were noted or measured in this particular exercise. But just to give you a sense of how big the voucher program is going, that was 330,000 services. About nearly 70% of the voucher beneficiaries were using the vouchers to purchase implants. The remaining 25% were using vouchers to purchase IUDs. The remainder then were other services, essentially either removals or permanent methods or simply counseling. The providers noted a significant increase in contraceptive uptake at their facilities, particularly LARC uptake, and they noted a significant increase in client volume. To give a visual on that, on the next slide, you can just see the aggregate number of vouchers increasing month on month in this plot between essentially March 2011 when it started and the end of 2014 when the program was winding down. So there was a large number of clients continuing to increase over time through this pipeline. Next slide, please. Using Impact 2, it's estimated there were over 200,000 unintended pregnancies averted and 520 maternal deaths averted in the 2014 services alone. So these were looking at we had to do it. Impact 2 estimates these averted health outcomes on an annual basis. So we were looking at the 2014 service statistics. It's estimated that the program saved $14 million in direct costs as a result of this. And it's to give you a sense of what we're talking about in aggregate at the national level. There were about 280,000 women who, of reproductive age out of Uganda's 8.6 million women who are using a method supplied by the program. So that's about 5%, 4% of the population were using a method supplied in this one particular program out of the entire population. Again, using Impact 2, there were 120,000 clients who were estimated to be additional users at the population level. This is a population level measure. It's not a measure of who's a new user, quote unquote, versus a recurrent user. This is a measure of how many additional individuals have been added to the total population size of users against the 2012 baseline for the FP 2020 campaign. So there are 120,000 additional clients as a result of the voucher program. And it's estimated the program contributed 1.4% to national contraceptive prevalence within the study period. So significant in this qualitative understanding, given the scale of the program as a large single program, not a national effort, but a single program from a single organization. Next slide, please. So just quickly sum up, this is existing private sector providers that are being contracted to expand family planning access and method mix by adding LARC and permanent methods to their package that many of them were not providing prior to the program. It's particularly meaningful for the population being targeted by the vouchers, those that were considered relatively disadvantaged compared to others using that poverty grading index. And the CPR was notably improved between 2011 and 2015 when the the subsequent DHS came out, and the contributions were quite significant, again, given that it was one program. There are remaining research questions, as is always the case, and there was a lot of interest in whether these higher clinic service volumes would also be associated with a higher service quality score. So as a result of the program, was program implementation essentially associated with a higher service quality on from a consumer-facing perspective, particularly with respect to method information index? And that's a question that I think future research would be very keen to be able to answer, as it would provide some feedback on whether the higher volume is stimulating a better level of care during the counseling session. There is a full paper, just to quickly note, there is a full study that was published last month in Global Health Science and Practice, and you can read more about this particular study in that issue. Thank you very much.
Great. Thank you, Ben. That was a great presentation and really provided some important data and evidence around the impact of a voucher program and what it can have on increasing contraceptive use, particularly for methods that are expensive, like long-acting methods. Thank you again. Our next presenter is Anna McKay from Mary Stopes International. Anna has over 10 years of field experience in working with family planning programming and is currently the Deputy Director for the CIFPO project at MSI. Anna, over to you.
Thank you, Nandita. So I'm going to briefly run through the results of a pilot that Mary Stopes International ran to increase family planning access for young people through the private sector using vouchers in Madagascar. Next slide. There's a high unmet need for family planning amongst adolescents in Madagascar. And we know that young people often express a preference for seeking family planning from the private sector because of, amongst other things, the confidentiality and privacy issues in the public sector. But we know that cost barriers in the private sector often prevent young people from acting on that preference. Mary Stopes Madagascar supports a franchise network of 150 small private providers across Madagascar. And for many years, Mary Stopes Madagascar has run a poverty voucher in combination with this franchise network to enable poor clients seeking family planning services to access those services free of charge through the franchise network. Mary Stopes Madagascar noted in 2013 that only 12% of our franchisee clients were under 20 years old. So we decided to pilot a combined demand and supply side intervention using our existing voucher management infrastructure. As Elaine noted previously, this infrastructure is administratively time-consuming and expensive to set up. So it's quite difficult to pilot a voucher program without having an existing infrastructure in place. Community health workers were trained in talking to young people and dispelling myths and misconceptions common to adolescents around family planning. And for those adolescents who were interested in taking up a family planning service, they were given a voucher which could be redeemed for a free service at one of the franchisee facilities who had been trained in youth-friendly service provision. The vouchers covered family planning counselling, a range of family planning methods, including short-term and long-term methods, screening and counselling for STIs, and removal of implants and IUDs if desired. Next slide. So what did we find? In the first 18 months of the pilot phase, we saw really encouraging uptake of family planning by young people through the voucher. So out of around 58,000 vouchers distributed, over 43,000 were used by young people to take up a voucher service. And you can see the range of services that were taken up in the pie chart on the right. Note that many young people chose to take up multiple services. For example, STI counselling as well as implant insertion. Over 3/4 of young people chose to take a long-acting reversible contraception, implants or IUDs, and over half opted for screening and counselling on STIs. Next slide, please. So who were those 43,000 clients? Mary Stopes Madagascar only started collecting detailed socio-demographic information in the final months of the pilot, but snapshot data from those final few months indicates that 69% of voucher clients had never previously used a method of family planning. 96% of clients were aged 20 or younger, which indicates that the voucher targeting mechanism for reaching adolescence was working well. And 47% had one or more children, suggesting that the voucher was successful in reaching both adolescents who wish to space their children and also, importantly, adolescents who wish to delay having their first child, which is a group that at Mary Stopes we have always found hard to reach. Next slide, please. Mary Stopes Madagascar began the pilot using an e-voucher, where the community health worker would send an SMS with a unique voucher code to the mobile phone of adolescent clients who were interested in taking up an FP service. We quickly found that these were not being frequently used, partly because a high number of the young people who were interested in receiving a service did not own a mobile phone, but also because even those who did own a mobile phone were reluctant to provide their number due to the sensitive nature of family planning in Madagascar and their reluctance to have an SMS relating to family planning on their phones. So we quickly established a new distribution strategy, reverting to a paper-based voucher, which was distributed at by community health workers at community level, and retaining the e-voucher component via Mary Stopes Madagascar's call centre, where, for example, if an adolescent rang up the call centre for advice on family planning and was then interested in taking a service, they would be sent an SMS with the unique voucher code, which could be redeemed at one of the franchisees. Next slide, please. Feedback from franchisees indicated that the youth-friendly training was useful, but what really made a difference was the increased youth client load, which really improved provider confidence and provider willingness to provide what is still a very controversial service, especially for adolescents in many of the communities in which these franchisees are working, particularly when it comes to long-acting reversible contraceptives. Next slide, please. In conclusion, these results demonstrate that vouchers can be an effective tool to reach adolescents at scale, provide them with family planning choice, and leverage existing private health infrastructure. And as a result of this pilot, MSI is now operating adolescent voucher programs in other countries, including Kenya and Uganda. The results show that when people have a choice of methods, many of them choose LARCs. We also have learned that you really need the supply side and the demand side components of this intervention for lasting success. Just doing youth-friendly franchisee training doesn't tend to give us lasting results in terms of increased uptake of services by young people. Similarly, a voucher program for adolescents without a corresponding supply side intervention to ensure that franchisees, that private providers are willing and able to provide services for young people with the respect that any other client would get, would not be so successful. And finally, mobile technology is not always the right solution. There are plenty of interesting applications and opportunities for mobile technology with voucher programming, but they need to be deployed carefully and with an eye to the context. Next slide, please. Finally, for those who want to hear more, Mary Stokes is co-convening an in-depth meeting on family planning vouchers with USAID and FP 2020 on the 31st of October in Washington, DC. And we'll be looking at voucher programming results, insights and challenges, and exploring the potential of vouchers in the future FP financing landscape. So I encourage anyone who is able to attend to do so to get a more in-depth understanding of how voucher programs work and some of the challenges and opportunities that we're finding. Thank you very much.
Great. Thank you, Anna. That was a great country example with, again, some more compelling data about how vouchers can be used to increase access, particularly among young people, that we all know is a very important group. Just a reminder to our participants that we will be sharing the presentations with you, as well as sharing a link to the presentations on the YouTube channels. And also, please submit any questions that you have, and if you have them directed to a particular panelist, please indicate that as well. Our final speaker is Muzam Ali. Muzam is a medical officer in the Department of Reproductive Health and Research here at WHO. He has both clinical and research expertise, and his main interest is in clinical trials, strengthening research capacity, and healthcare financing. Over to you, Muzam.
Thank you very much, Nandita, and thanks very much again for giving me an opportunity to share the key results of a voucher intervention project in family planning in Pakistan. The intervention period was between 2011 and 2015. Next slide, please. Just to give an overview of the background regarding Pakistan. Pakistan is a large population of around approximately 210 million, the sixth largest, according to the latest census in 2017. It has a very high total fertility rate of 3.8, combined with very low contraceptive prevalence rate of 35%. And among this 35%, 26% are for modern contraceptive, the rest is for traditional methods. And within this 26%, LARC remain very low for around 2 to 3% of the total modern contraceptive prevalence rate. It is also important to note that there were, according to a survey in 2012, 9 million pregnancies were reported, out of which 4.2 million pregnancies were considered unintended. There are also inequities in urban and rural populations, especially in the context of service provision, but also the distribution of health workforce, the doctors, the nurses, and other trained providers in family planning. In the past 2 decades, we have seen increasing role of private sector in family planning service provision, where at the moment they cater to around 42% of the population who seeks family planning services in Pakistan. Next, please. The main objectives of this project. In the next slide, I'll explain a little bit on the design, but the main purpose of this single-purpose voucher approach by Mary Stopes Society, which is an affiliate of Mary Stopes International in Pakistan, was to increase the uptake, use, and better targeting of modern contraceptive method among the lowest 2 quintiles in Punjab province in Pakistan. At the bottom of the page, you can see on the right side a picture of the paper voucher that was distributed with the barcode on the top that helped in the verification and providing some checks and balances for this redemption. So in this picture, you may not be able to understand, but it is basically mentioning that the voucher can be used for implant, IUD, condoms, pills, and injectables. So all these services were offered through this voucher. And the voucher had 3 components. First of all, of course, the services, then follow-up of those services and side effect management, and particularly in the case of long-acting reversible contraceptives, the removal services when need be. Next, please. So the Mary Stopes used a combination of social franchising and voucher to reach out to the underserved in the selected areas in Punjab. And as I mentioned, it was a quasi-experimental study design with pre and post intervention. We had an intervention and a control arm. The intervention time was approximately 30 months. We recruited the clients for this particular survey through multi-stage cluster sampling. Around 1276 clients were in the intervention and control area. And the districts which were the intervention and the control, they were selected based on the comparable socio-demographic and health indicators. And also we ensured that the distance between the districts are reasonably large enough so that to minimize the contamination of the intervention in this study design. Next, please. This, I think Elaine and Ben have already alluded to it, but just to give an overview of the voucher management system in this particular program, it gives an overview of the sequence through which the whole process of developing, printing, distribution, and ultimately the redemption and the reimbursement is occurred in this program. So if you look at the left side, there is a sequence number of 1, 2, 3. So you can see that the development, printing, and the distribution was done by the Mary Stopes International. It was distributed in the field via the district manager and the senior field supervisor, and they were looking after the field worker who would identify the client, distribute the vouchers, and of course cause community awareness and mobilization. It was given to the client who would avail the services from selected identified providers, and the providers, when they would provide the services, they would redeem vouchers from Mary Stopes International. Now there were 2 sets of, I would say, verification level. First, the voucher would go to the senior field supervisor who would check and verify, and then at the second level, there was a district manager in this program who would again make sure that there is no fraud or pilferage, and to ensure various checks and balances are in place, verify, and finally it went to the finance department of Mary Stopes, who would then reimburse the service provider based on the services provided. Next, please. Now, this is just to share some of the key results that came out of that particular study. What I'm going to show in the next few slides is that what was the status at the baseline, end line in both intervention and the control area. So just to give a very quick overview, the age of the married women of reproductive age were similar at the baseline and end line in both the arms of intervention and control. Similarly, there was no major differences in the age of the husband in both the intervention and the control area. There were some changes in the average household size from 6.5 to 4.9 in the intervention area, but no effect on the control. Next, please. Now, this slide basically provides an overview of the use of the contraceptives. So on the left side, you can see there are two figures, one on intervention, the second on control. So in this one, you can see we are giving an overview of how the contraceptive was used. So if you compare the baseline with an end line, you can see a huge difference from 21% in CPR to 51%. But in the control also, there was some increase from 18 to 32%, but there was a huge difference in the intervention and control area. Looking further deep down, if we look on the right side, we have again the intervention and the control. Here we are trying to see what was the changes in the modern versus the traditional method in those intervention and control area. And as you can see very clearly, there was increase in the modern method compared to baseline and end line in intervention, and also a slight increase in the control area for the modern method, but also in the control area you can see a slight increase in the traditional method as well. Next, please. Now, I just want to emphasize on 3-4 points in the slide. I'll just take you through in some of the key things. So if you look at the top line, there is information on the control area where we have baseline and end line, then intervention area, then there is a term called absolute difference and the net effect. So absolute difference is basically the percentage change from baseline to end line, and the net effect is the percentage change in intervention groups minusing the percentage change in the control. So I'll be targeting and focusing on the net change based on various indicators shown on the extreme left side of this figure. So you can see that overall the ever use, the current use, and the use of the modern method increased substantially, especially the modern method. The net effect is 26%, which is shown on the right side column under net effect. And similarly, very interestingly, IUD has shown tremendous increase in the net effect, which is up to 16%. So that is basically comparing control and intervention and taking care of the baseline and end line also. So huge differences were seen, and also, especially in the context of Pakistan, implants are not popular because, first of all, they are not available in most of the sites, and also many of the rural women are not aware of this particular method. So we saw, I would say, in the context of Pakistan, quite some increase, which is 2% though, but still very, very high in the context of Pakistan. Next, please. Now, this is a very interesting slide. One of the key concerns is whether the voucher can help in decreasing discontinuation and increasing switching of the methods. Because voucher does not come alone, it comes as a package of better counseling, availability of services, and ensuring people are aware. So we just wanted to see what is the state. So in the slide, you can see there is again intervention and the control area. So there were 842 women who reported using a modern method during the last 24 months when the survey was taken. And out of these, 13.7% discontinued method. But interestingly, 46.6% among those who discontinued again switched to another method during the same period. So if we compare the intervention with the control side, we can see decrease in the discontinuation and increase in switching, perhaps due to better counseling and availability of different methods compared to the control side. Next, please. This is my second last slide. Here, just a couple of messages from this slide. Basically, we were interested to see whether we were able to reach the poorest who need the services. Are we targeting the right people? So that was the question in mind when we were looking at the data. So if you look at the lower portion of this slide, you can see that those women who are among the poorest, which is highlighted in yellow, those women who are the poorest and the poor, the odds of having better contraceptive knowledge, ever use of any method, current method or the modern method, are comparatively higher than those which are in the average rich or the richest quintile. So basically, the key message is that we were able, through the voucher system, we were able to reach to those women who actually needed the services, and they were actually using the services at the end of the day. Next, please. So in conclusion, through this voucher intervention program, the program was able to reach, to increase the uptake and utilization of the modern contraceptive through clients' empowerment. They were able to reach out to those who need the services, and I think very importantly, they were able, through the IEC activities, but also through the field workers, they were able to connect the client with the facilities where they can get the high quality services. Social franchising is definitely a tool that can engage the private sector, because in the private sector, the key concerns are the quality and the cost control. So with the help of social franchising and the voucher combination, we were able to ensure the quality and also some sort of cost control. There are certain questions that are still need to be answered, and as Nandita mentioned earlier also, the evidence is building up. We are not there yet. So we are trying to see whether the means testing, the poverty score, or the geographical targeting are more effective, which method is more effective in reaching out to the poor. And then we are also faced with challenges of sustainability and scalability. Although the evidence is building up, but we still need more research, we still need more evidence from the field to understand how to take the project to scale, and also to look beyond the project timelines. So I end my presentation here, and back to Nandita. Thank you.
Great. Thank you. Thank you, Mozam. That was another great research study that really demonstrated the effectiveness of vouchers on it, not only increasing use, but also reducing discontinuation rates and increasing switching to perhaps more effective methods. Thank you again to all the panelists for your thoughtful and engaging presentations. We have a few minutes to take a few questions. So thank you to those who submitted questions. The first question is for Elaine, and the question is, how can vouchers be connected to or leveraged in country settings where health insurance schemes are present? Oops.
Nandita, go ahead and ask the question again.
Okay. The first question again is for Elaine. The question is, how can voucher programs be implemented, leveraged, or connected in country settings where national health insurance schemes also exist that are in theory supposed to provide services for free? Okay.
Right. Am I unmuted now? Sorry about that. Very good question. I might ask some of the presenters to share, because I believe in Uganda, the voucher program may now be in the process of morphing into the early stages of insurance, or at least the government taking that on. But I think the one thing that vouchers, we know that it can help us, is to target those resources toward the poor, who are often left out or the last in these national health insurance programs. So I would at least note that. One thing that we hope is that it can include private provision. And a lot of these national health insurance programs were starting with government facilities, and yet we know that the private sector and the private networks of health facilities can help us expand our reach and coverage. And finally, I might add that one other thing. Vouchers for family planning are including family planning and the details of what it takes to include a range of methods. Most of the national health insurance programs struggle with this, and it's sort of an iterative process to add methods or include them or think about the best ways to do so. So I would say that as well. Maybe the other presenters would like to chime in if there's other things I may have missed.
Elaine, this is Ben. I would add, I don't think you missed anything. I would just say that, or emphasize the community-based role that many of these vouchers have in demand generation. And it's interesting to consider both with national health insurance and with scale-up of community health worker programs where the injections, for instance, become a service that CBDs or CHVs may begin offering in the community context. The vouchers become a way of complementing service delivery at facility as well, or thinking about ways in which vouchers could strengthen both demand generation for referral to facility for LARC and PM, as well as strengthen the role of community-based services. So in a context with a national health insurance model that may lean more public sector initially and may lean towards the higher end of the economic distribution, voucher programs can help to equalize all these different dimensions, across all these different dimensions. They can certainly address the lower socioeconomic quintiles. They can address or help to refer clients to private sector as well, and strengthen this community-based presence, be it service delivery at the community level or at least referral to providers at facility.
And just one more thing to add is that at times national health insurance programs are targeting higher level facilities, and we know that some of these voucher programs are working with lower level facilities, midwife operated facilities, where many lower rural people are accessing, or those who have less ability to pay are accessing.
Just to build finally and briefly on Elaine's comment, we see voucher programs as being able to act as a sort of precursor and proof of concept often for national insurance schemes, particularly in terms of demonstrating to governments the role that the private sector can play in reaching disadvantaged groups when cost barriers are removed, and helping to sort of ready private providers, especially smaller private providers, for many of the processes that will be required for insurance, including accreditation, claims processing, reimbursement, etc.
Great.
Yeah, this is Moazim. I also would like to reiterate what my colleagues have mentioned. I think these voucher programs, although sometimes they're part of, or we have national health insurance programs in some countries, but they are not covering all the sectors. They're not covering all the women who are actually needing the services. So voucher can complement, especially in rural areas and those ethnic minorities or special groups like adolescents, by reaching out to them and ensuring that they are able to utilize the services when they need it. So I think even having a national health insurance program is good, but voucher can actually complement what is being done and how ensure increase in reach to those who need the services.
Great. Thank you for the responses. We're getting close to time, but I think we have time for one more quick question, and this is directed to Ben, and it's an important question that has come up a few times. Is there any cost-effectiveness data available? Or can you give an idea of what was the typical value of the voucher and the management system per user?
Yeah, there was one report that MSH put out comparing, if I have it right, the voucher program to a oh, what was it? There was a Uganda. Anyway, there was a report from Uganda that did look at cost effectiveness and vouchers. I don't recall more detail than that right off the top of my head, but it was part of the ASH project. Came out about a year or two, maybe 2 years ago. There isn't a lot of information on cost effectiveness of vouchers per se, or vouchers compared to some alternative. Generally, with family planning, you'll see that the service reimbursement is a modest amount compared to other health services like, say, maternity care, delivery cost. So what happens is that there'll be a certain setup cost and running cost for a voucher program, and then this distribution or service fee that needs to be paid to providers. So some metrics may look better than others, and it's important to keep in mind ultimately what additional service is being provided to populations who otherwise wouldn't be able to access these services, I think, because I recognize that family planning services themselves are not necessarily expensive per person, per service. So there is that. And I'd be glad to look at this more. It's certainly an important question that needs to be explored in more detail, and there are service statistics that are around this and program management data that could be pulled apart, as we did in this last paper that I presented, to answer this using routine information.
Hi, this is Moazim. I'd just like to add on from the Pakistani experience. We calculated some costing per voucher service. When I say costing for voucher, it includes the fixed assets, the staff salaries, the training services for vouchers, printing, reimbursement, and overhead cost. So for each voucher that they distributed, the average cost was around $25. Like I mentioned, it includes the staff salaries, the training, the printing, reimbursement, and the service inclusive. So approximately $25 per voucher.
Great. Well, I'm sorry to say we're well out of time, but thank you again to all of the panelists for your excellent presentations and to all of our participants for your thoughtful questions. The recording and presentations are available on the links you see on your screen, and we'll be sending the presentations to all of you who registered as participants. For more information on the high impact practices in family planning, IBP initiative, or FP 2020, you can visit the websites listed there. And please follow us on Twitter at #IBP initiative and #HIPSForFP. Thank you again to IBP, FP 2020, and the HIP initiative for hosting this webinar series. And thank you again to the presenters and all participants. Bye.